Good morning, ladies and gentlemen. I am Dr. Kanyika Chamni Prasad, and
Hello everyone, I am Danetip Nimskun from Chulalongkorn University.
we will be the moderators for this session. It's about the tailoring cartilage, tissue engineering for knee regeneration. We will have 4 speakers. Each will present around 10 minutes, and we will have a Q&A session for 20 minutes at last.
Okay, so our first speaker, please welcome Dr. Puapong Nimkingrat from Chiang Mai University, please.
Right. So good morning, Ajahn Kanika and Ajahn Danai and ladies and gentlemen. So the first session is going to be the knee, right? So we switch a little bit and we are going to move on to the knee cartilage. So the tissue engineering and regeneration for the knee. So the topic is something about tailoring the cartilage, but I would say that there might be different or not different from the whole aspect of the cartilage repair lot. So I have no disclosure for this talk. So common scenarios for the knee, when we think about the cartilage, it is not just only the cartilage injury itself, but we think about the degeneration as well. So that's why we can call it like focal or global cartilage injury. Apart from that, we can think about osteochondritis dissecans, which is one of the pathology that can be happen and get the problem for the patient in the joint. The first thing is that before we move on for the treatment, we should think and evaluate about how we treat and how to evaluate and consider about the pathology. So please try to think about the history taking. First of all, think about the PF loading or any kind of subchondral bone overload or even the history of the injury itself, and evaluate several factors including like BMI or any kind of expectation of patient would be one point of the history taking. Physical examination can be very useful information for us. It is not just only the lesion itself, but we should think about rotational profile or any kind of alignment as well to be able to make sure that it is not just only the single problem. Sometimes it is multiple problem with the morphology and the malalignment of the patient. And after that one, we can think about imaging, to use the proper imaging for that. The evaluation itself, from the basic radiographs should be useful. For example, if we try to use like the tunnel view or any kind of intercondylar notch view, would be useful if you suspect or expect something in the middle of the joint. However, to get more in detail of the investigation or evaluation, some kind of investigation, for example, MRI or MRI arthrography would be useful to see any kind of the cartilage lesion, for example, delamination, full thickness, or the bone bruise. That would be useful to see and then observe for that one. However, if we have seen and then we identify, the lesion already, we can think about the possible classification to be useful to deal with this problem. For example, like we use like osteochondritis dissecans for the staging for that one or any kind of scanning. That would be useful. And then if you got that one, the classification from plain radiographs or even the MRI scan, when we move on and then we do arthroscopic examination, we might think about more detail that we got from that. So we can compare that one. For example, we think about the lesion, we think about the detachment or the area or the size or any kind of the fluid over there. That would be useful for that. I give you the example that in our team, we try to study and we think and we would like to evaluate about the subchondral bone edema or bone bruise, of the articular cartilage. So we did the study in the multiple knee injuries of the patient. We include some patient, around 200 patients, and then we found that, for some specific area of the movement, for example, at the posterior side, we detect several specific area of the bone bruise at the place of the posterior side of the knee. So that means, from the beginning, when we detect anything like edema, that could be useful information for the further progression of the cartilage injury itself. However, when we think about the morphology, we can classify into several layers depending on the depth of the cartilage. For example, from the top bed, we call like superficial region, and then to the deepest bed, we call the calcified region. It depends on how deep the lesion goes. For example, if you go just only 50% of the cartilage, that could be classified as ICIS grade 2, for example. However, if the lesion or the injury breached to the depth, the deepest part of that one, that means it breached the calcified region. That would be the full thickness of the region. About the treatment, definitely there are two ways of the treatment: non-operative treatment and operative treatment. So when we are here at TOSL meeting, sometimes we ignore and we forget about the way of non-operative treatment. Weight bearing, weight sharing, or even with the medication. For example, like the previous talk that we discussed about the use of biologics or anything that would be useful for non-operative treatment. It is easy and there's less risk and less dangerous things for the patient. However, if we cannot deal with that one, we have to think about operative treatment, which is going to be the second goal after we try non-operative treatment for a while. There are several strategies that we have to deal with the cartilage, not especially with the cartilage at the knee. You can use this strategy as well with the whole area of the cartilage. However, when we focus at the knee, we might think about two things: surgery and non-surgery. When we talk about surgery, there would be several options from microfractures using the scaffold or any kind of cell-based therapy. However, when we think about other things apart from the surgery itself, exosome, cell-based therapy, or even PRP or mesenchymal stem cell would be the option. Apart from that, growth factors, mechanical stimulation, or even like environmental modification would be options as well. To talk briefly about the operation, we might get used to the palliative surgery, which means we do debridement to remove some of the debris over there at the joint. Reparative procedure, the most common thing that we normally do is that a basic chondroplasty or microneedling. Restorative procedure comprise of whole tissue transplantation or even like ACI or autologous chondrocyte implantation. It depends on the treatment because right now there are several algorithms that we can follow. For example, followed by the depth, followed by the size, followed by the demand of the patients, or even with the first goal or the second goal. For example, if we have to deal with the primary treatment, we have to think about something less invasive first. However, if we do or we have to deal with the revision surgery, we have to think about something more complex. For example, ACI or cell-based therapy. In 2021, we mentioned about more things, especially for the knee, for example, like the grade 3 or grade 4 of the cartilage lesion. They add on, like in this paper in Cartilage 2021, that they add on some like cell-based therapy into the recommendation. Although the recommendation is not that high, it is also in the intermediate level of the evidence. Please follow that one. But when we classify the injury itself, we normally use like the size and the depth and the lesion area as well to be able to make sure that you do and then you make a decision of right thing. Biologic things comply with several things, but the main concern is that we use several more conditions. In the morning, I think lots of people mention about the cycle like this, but I would like to add on that we have to think about something about the biology as well. So that's why in my cycle, I add bioactive effects as well. For example, cold culture or environmental manipulation for that one would be useful. For example, drug exosomes or anything or any growth factors. This is like in this topic that, okay, for example, if we use tissue engineering strategy, normally we use the cells. The cell is very important, for example, chondrocyte. If you track back and trace back to the first tissue engineering in orthopedic surgery, we might think about New England Journal in 1980s that Professor Matt Ripper do the chondrocyte implantation for that one. However, nowadays, we try to move on into more of the 3D constructs. So that's why lots of paper mention about using the scaffold of that one. Combination of the scaffold with cells would be one of the useful tips and tricks for that, and there would be the good factors. And then several paper mention about adding on of the growth factors or any kind of cells or manipulation to be able to make sure that the cells that you transfer into the joint is fit enough. I give you the example like in my study. We use the human embryonic stem cells that manipulate and then culture with the BMT2 and BMP4, and then we implant into the animal models. And then we found that after a month time, there is more like representation of the tissue. And then when we wait for several more months, we found good healing of that one with the showing of the collagen 2 staining, which is going to be the good marker of the cartilage. However, when we use the scaffold, we have to think about several things about the pros and cons, biodegradable properties, and any drawback of using any type of the scaffold. Bioprinting or any kind of things are going to be one of the good options as well to add on for the scaffold manipulation. And as well, like I mentioned, that external stimulation, mechanical, electrical field is one of the things that we normally add on nowadays to make sure that we got good construct and then we good bio properties for that one. When we look at the strategy, there are several strategies to deal with the repair. I can give you the example of the one paper that in the knee joint, there are cells-based therapy, lots of cells-based therapy. And this is like the meta-analysis to show that there are several trials that going on. And then it found that, the cells-based therapy, especially for the knee joint, can get like better pain score in terms of vision of scales and then bone mark, and as well as like chromosome and knee scale score. However, we have to think about the long term and evaluate the histology finding as well to be able to make sure that it is good. Right, in summary, tissue engineering is promising, especially with the knee, because this is like the big joint and then the joint that we normally have to tackle with. However, there is no definitive solution at this moment. Thank you very much.
Thank you. Then we should move to the wrist and elbow that will present by Dr. Tunyaprit from Ramathipudi.
Thank you, Ajahn Kanyika and co-moderator. So I going to talk on the tailor on the small joint actually for the wrist and elbow is represent for the small joint cartilage treatments. So why the small joint and the large joint is different? Maybe the small joint, we have to concern with the instability course, and also the small joint is non-weight bearing. That means motion is very important. And the nature of osteoarthritis is come up with the idiopathics, maybe primarily in nature, most of the osteoarthritis. And why it's less interesting? Because I think the basic stuff is fibrocartilage. You can manage the cartilage in upper limb by the fibrocartilage regeneration. It's healed by themselves, but the quality of the cartilage is not that good. The knee joint is the large joint is something different. You need the hyaline cartilage, but the upper extremity, you just okay with the hyaline fibrocartilage. And the evidence is quite less. So it's not attract the market in this area, yes. But it will be, I will talk on the case that I did it. So the indication for the surgery with the cartilage start with the elbow cartilage or the wrist injury problem that you have to deal with the cartilage and also hand arthritis. The OCD of the elbow is represent of the cartilage defect with the subchondral bone problem, I think, is like the two theory, the vascular theory and also repetitive theory can make the subchondral bone injury and further cartilage to the damage to the cartilage. Subchondral bone is unstable. So you either do just simple removal for the fragment or fixation, or you can do the cartilage regeneration with the cell platelet technology. We did the cartilage platelet and put in the defect. You can do with the arthroscope or open lesion. We believe that if you just simple Tailoring, you can get the fibrocartilage, but we try to do hyaline cartilage by tissue engineering for the cell platelet without the scaffold. We can culture in the platelets and put inside there. We have to do dry scope and put with the some sort of glue. And this another condition we call the plica of the elbow. As you can see here, you can see for the radiocapitulum joint here, the radial head. You can see the cartilage defect is caused by the plica that can injure the cartilage. And before the operations, some guy injection for the steroid first in between this joint. And we can see the steroid chunk between the radial head and capitulums. So we need to remove the mechanical obstruction, because if you keep the plica there, it may further impinge for the cartilage and turn the radial head into arthritis. So we believe that if we remove the mechanical obstruction between the joint, because the elbow is a hinge joint, if you have the plica or maybe some sort of foreign body, it might make the elbow accelerate the arthritis. So we just remove the pica here for the arthroscopic here, and the ECRB is quite good in this case. So we go with the lunate, the Kinbock condition. The Kinbock is caused by mechanical, it's like nutcracker with some sort of force that involved into the lunate bone. And the second theory is vessel. It's like the vessel theory. Is insufficiency of the vessel that supply into the lunate by anatomy. So there are two theories that can cause the Kinbock disease. In Kinbock, in my hands, we do the microsurgery, but we can do less invasive with just debridement for the lunate and decrease the pressure at the lunate bones. So it can turn from the left hand side to the right hand side. Its bone can regenerate and cartilage can regenerate into fibrocartilage and make the surface smooth for motion. I think this is dry scope for release the pressure of the lunate bone. So we can go to the STT arthritis, which caused by idiopathic mostly. You can see the STT joint here. We can do with very minimal invasive to the joint, STT joint, to resect the arthritis out and create a new fibrocartilage to rebuild the STT joint. And slack wrist is caused by injury for scaphoid lunate ligament. We can do repair, acute repair, or if we leave the SL injury and turn into chronic, we cannot repair. We have to deal with the ligament reconstruction of the wrist to make the stability of the wrist better. Right, so we create the cartilage protection of the scaphoid. We just wrap around the scaphoid. But normally, when we do this type of injury reconstruction, you have to make the hole at the scaphoid and make the cartilage damage. But we develop the new technique that wrap around the scaphoid, not involved in the cartilage. We protect that. And this is the tissue engineering by use the acellular human dermometric. When you get the wrist arthritis, normally the surgeon do the proximal lobectomy, get the bone out, arthritis out. However, in some state, you have to fusion with the wrist joint, which is not good. Fusion is a reliable procedure, but the patient doesn't like it. It's pain reduced, but the motion is limited a lot. So we try to create the new joint by use a cellular human dermometric put in between the joint, even in the grade 4. We believe that this can create a smooth motion for the wrist instead of fusion, but we maintain the preservation of the wrist joint. And this is an arthroscopic assist for the cartilage management as well. We deal with the interarticular fracture. We have to use to make the cartilage smooth. We can see in the joint. Normally, the distal end radius fracture you see from the fluoroscope. However, if you put the camera in the wrist joint, we can manage the cartilage defect better. So there's a lot of technique that can reduce the interarticular fracture here. And this is one of technique. We can see the dye punch. Normally, dye punch can reduce by arthroscopics and make the cartilage smoother. The joint congruence is better, and we expect no osteoarthritis develop in long-term follow-up. This is from fracture. We can deal with the fragment inside the joint here. This is the outcome. We can reduce, make cartilage better and heal better. So this is one of the cases that we do for scaphoid as well. The scaphoid management, you have to make the absolute stability, make the cartilage, the joint surface, no stepping. So we can check with the cartilage with the arthroscopics and fix the screw at the joint from the wrist joint. This is one of the my case. Okay, turn into the osteoarthritis of the hand. Hands mainly is from systemic. I think hand is genetic disease. We accept that. So it's not extract for the cartilage restoration, but I can make it more interest by use the osteochondrograph from the ribs. You can use the cartilage and bone for the rib to make a new joint. You can see the arthritis of the PIP joint. So normally it's filled already, but the patient would like to move. So what we do, principle of osteochondrograph is make the cartilage from the rib, put the new joint inside to make the proximal end and distal end. It make the joint motion again. So this is the principle. But in the past, we just fusion, but we can create a new joint. And for the osteoarthritis of the thumb, we call the first CMC, we can do the similar to the sport as well. We can do the microfracture at the early stage here. We debride first, get rid of the debris out, synovitis out, and you can see the blood is come from the microfracture. But I think next time I can do better by small KY. That time I use the a drill. It too big, I think. So we can develop nano microfracture. You can see the blood come out after we do the arthroscopic. So this is the principle from the cartilage that we learn from the large joint into the small joint. You can see the breathing and make the fibrocartilage really better. So if you can make the joint happy, you can happy with the create motion. I think the motion is key for treatment in upper limb. Make from fusion to be joint preservation in upper limb. Thank you very much.
The next topic will focus on the hip by Professor Jiang Qing Chuan. May I invite Professor Jiang Qing Chuan, please?
Okay. Professor Ching Chuan Jiang, he is currently working at Fujian Catholic University in Taiwan, and he graduated in National Taiwan University School of Medicine, and further his studies in residency at Department of Orthopedic Surgery, NTU Hospital. And also he conducted his research as a research fellowship at the Department of Biomechanics, the Hospital for Special Surgery in Cornell. And he did his PhD in NTU and his MBA in NTU. And for his professional experience, it is super long. Okay, so some of the highlights I think are his numerous awards, and he held many positions in Taiwan and a lot of academic positions. So please.
Thank you. Good morning. First of all, I'd like to thank the TOSSM invite me to this important meeting, and I'd like to thank moderator Professor Gandhika, Dr. Mun. So today my topics about the hip is about the clinical, is a clinical trial. A few years ago, I have done in National Taiwan University Hospital. So I think if for the hip, a vascular necrosis is far more common than the cartilage injury. So the treatment here, we take care the avascular necrosis of the femoral head as well as the cartilage. So the etiology of the osteonecrosis of femoral head, although there are many causes, but vascular issue is the main cause. And the people of avascular necrosis is pretty common in Asian country, from Korea, Japan, Taiwan, Thailand, even to the Saudi Arabia is pretty common. So if this condition become neglected, the final result is total joint replacement. So the goal of our research is try to treat this lesion in early stage to prevent them for the joint replacement. So we focus on the early stage. The MRI staging of the osteonecrotic femoral head, we can group into 6 groups, but we focus on the stage less than stage 3. So the conservative treatment for osteonecrosis of femoral head include medication. I think sodium bisphosphonate is pretty successful to treat the early osteonecrosis. And lifestyle modification is also very important. There are some biology and regenerative therapy. Well, this is no definite evidence to support. So the surgical treatment include cold decompression. According to my personal experience, the cold decompression is only count for 60% of the patient have a satisfactory result. The other 40% has turned out to be total hip. And today I'm going to introduce to you innovative osteochondral regeneration treatment for the early femoral head osteonecrosis. The background is I have lead a team with the National Taiwan University and the ITRI, Industrial Technology Institute in Taiwan, to develop a biphasic cartilage regeneration device for the knee cartilage regeneration. I'm very sorry, I should be here yesterday, but I have some more important meeting. So I have a video presented yesterday. So if you have any questions, probably I can answer you the question in the next topics. So in this study, we apply this matrix to the hip region. So this clinical trial, the purpose is try to evaluate the efficacy and safety for the osteonecrosis treatment. I'd like to show you a very cartoon to explain to you how we perform it. You know, the patient lying on the table under anesthesia, and we do the cold decompression and take a column of the femoral bone, take out. So this cold decompression will include the necrotic area. So we can management this column of the bone on the operation table. For the cartilage part, we can digest the cartilage with enzyme and put into the matrix. And for the osteonecrotic part, we just chip it away, for the pathological examination. So the rest of the column is healthy femoral bone. So we fabricate the end of this bone column and put the matrix to the tips. Then insert the whole column of the bone, this healthy bone, back to the original place. So on the distal part, there's some bony defect. So we fill up this defect with artificial bone. So we own the pattern for the cartilage for US pattern and Taiwan pattern. So the clinical trial is follow this protocol. We select 20 patients, 10 for experiment group, 10 for control group. The control group is called decompression. The inclusion criteria is as follow. So it must be MI stage less than stage 3. And some of the people have previous other operation excluded, and the pregnant woman excluded. And this follow condition is IA is excluded. So the evaluation method include assess the subchondral bone and articular cartilage by MRI. So this is the follow-up protocol of our trial. We follow patients for 2 years. And actually, we have followed them more than 2 years right now. So there are some statistic analysis to evaluate the result. Of course, we have done preclinical animal study, use millipig. And Professor Pierre, he at that time studied with me, so he have a chance to join with me to do the animal study, some of them. So we do have evidence for the large animal. So we run to the clinical trial in human. And this get approval from the government health authority. So I'd like to present to you the first case is on the experimental group. She is a 56-year-old woman and diagnosis of osteonecrosis of left femoral head. The chief complaint is hip pain for 6 months, and he have no other diseases. On your left-hand side is the pre-op X-ray and MRI. We can clearly see there is osteonecrosis in the femoral head, and on your right side is the 1 year post-op. We can see the necrotic area disappear, and the joint cartilage is preserved. So this is the during the operation. Probably Pierre was here, probably. So we do the operation through the CM guide to do the cold compression. And our assistant prepared the cartilage. So we can use oscilloscope, insert into the hole to clear the pathology part of the osteonecrosis and take the specimen for pathology. So in the future, we probably can add some more adjuvant therapy like to this area. And the tissue for this patient clearly showed an osteonecrosis. So the next patient is the 42 years old female. He was randomly to the cold compression group. So we can see the pre-op X-ray is clearly osteonecrosis. The cartilage is intact. So we have done the cold compression, but unfortunately, 6 weeks later, the cold compression failed, and he went on for the total hip replacement. So during the cold compression, we do measure the intraosseous pressure. So as you can see here, pre-op, the intraosseous pressure is pretty high, but after operation, the intraosseous pressure decreased. So this is the rationale for doing the cold compression. So we have a preliminary conclusion for this clinical trial. 10 patients of experimental group and the 10 patients with the control group were performed uneventfully. There are no perioperative complications in both groups. Immediate pain relief in 18 patients of the both group were observed. 2 of the control group have been converted to total hip during the trial periods. So the experimental group can provide a minimum invasive endoscopic approach for direct visual examination of the lesion sites. It also opened a venue for further therapeutic management to the osteonecrotic femoral head, as well as the cartilage injury. So I'd like to acknowledge the National Taiwan University and the Industrial Technology Research Institute, and this fund is supported by the National Fund. Thank you for your attention.
Thank you, sir. And the last topic will be around the ankle, presented by Professor Jiran Pinan from Chulalongkorn Hospital.
Thanks to the moderator, and good morning to all the audience. So today my topic will be about the site-specific regeneration of the ankle. Okay, the ankle joint is a unique joint with the special characteristics with its smaller surface area that need to bear high load during walking and running and jumping and all activities. So there's a high contact pressure on it, and also the layer of the cartilage of the ankle joint is quite thinner than the knee cartilage, and the etiology of damage can be is more from trauma than from primary osteoarthritis, and also including the other causes like instability and impingement. So the current options for ankle cartilage repair includes microfracture or OATS or allograft, and the autologous chondrocyte implantation, which each of them has limitation. The microfracture frequently leads to fibrocartilage with inferior in mechanics and less durability. And for the OATS, there will be the donor side morbidity from the harvesting the graft, and if we use allograft, the risk of disease transmission will come into concern. And also with the supply issues and the challenge in integration of the graft to the adjacent cartilage. And chondrocyte implantation, either with or without the scaffold, There's also the challenge of integration and maturation, and with high cost and the needs of multi-stage operation. And even with the image, that's now can be the single stage. Also, there's a concern with the maturation and integration. And with all of them, with all of these traditional methods, whether they are account for the ankle with the specific biomechanics and biology. Okay. And okay, for the ankle joint, so with this, why the tailoring the cartilage for the ankle joint is crucial. First, with its character of high contact pressure that require, so the regenerated cartilage need to have a strong mechanical property, which the chondrocyte should be the hyaline like cartilage, and also with the good integration to prevent further delamination, and also with the thin cartilage with less inherent shock absorption. So it requires more reliance on the subchondral bone. Therefore, the subchondral bone health and architecture contribute more to the cartilage health. And also, with the thala motion that's in the constrained mortise, any abnormal loading will lead to the focal high stress area. Either it's from a fracture, which is the most common etiology, or instability or any malalignment. And if you look into the disease of the or the clinical problem of the cartilage of the ankle, there's a propensity that the problem of the of the bone and cartilage that will occur together, which usually we call it the osteochondral lesion. So they come together. And with the character of the cartilage of the talus, that's different from knee cartilage, with a higher equilibrium of modulus and the dynamic stiffness, with the denser extracellular matrix, with a higher content of sulfated glycosaminoglycan and lower water content, with the lower hydraulic permeability. And even in each zone of the cartilage, in each layer, the knee cartilage has a higher cell density in the superficial zone than in the cartilage. So the ankle cartilage has quite in each zone the cell density is the same, but the knee cartilage, it has a higher cell density in the superficial zone. That's the zone with the greatest interstitial fluid flow and mechanical deformation. And as I mentioned, that the talus cartilage is stiff than the knee cartilage. The tibial plafon, it has even a higher mechanical property than the taladome. So with all of these special character of the cartilage of the ankle, so when we wanna regenerate the new cartilage, all of each components of pillars of tissue engineering will be taken into account. That the cells, the type of cell, which one is the best one to that can be regenerated into the hyaline-like cartilage and durable cartilage. How much the cell density that we should see it in, or it should turn to be. And even in each cell layer, that's probably should have each difference of each layer of the ankle or the knee. So the cell distribution and homogeneity of the cell, how can we make it distribute into each layer as we desire. And also the bioscaffold, when we concerned about it, that whether we want it work ex vivo or in vivo, and its delivery, that's we need to think that which way of delivery method that we want to put the scaffold in, because of the constraint motif of the ankle make some location inside that's difficult to access. And the how can we make the scaffold that mimic of the native tissue to yield a better cartilage regeneration with a proper material properties? And do we need to make the scaffold with the gradient or hybrid, which each layer has a different characteristic by printing 3D or by other methods? And do we need to add like a smart biomaterial for induction of the cells or releasing of the molecules to make the cartilage regenerate better? And also with the growth factors and biologic of the cartilage that we can use them as adjunct for the cartilage regeneration. And also with the importance of the subchondral bone and loading, that we need to address the pre-existing pathology of the subchondral bone, either by bone graft of the cyst or realignment, the stepping of the joint. We need to make ankle motif stable and congruent. And any abnormal loading need to be eliminated by debridement of the bony impingement or realign of the malalignment and balance the force that cause the dynamic imbalance of the tendon and muscle. And the need for offloading during waiting for the cartilage repair, either by non-weight bearing of ambulation of the patient, or even by distracting the joint by the fixator. There's still a lot of challenge and future direction in cartilage engineering in the ankle. Okay, it will move forward to the more patient and site-specific cell and scaffold, to how to make all these things pass the standard and regulation body to make it cost effectiveness with the long-term durability, with the enhancing of vascularity of the construct, and also the integration with the host tissue and the immunogenicity also need to be taken into account. And when we do everything already, how do we know that performance of them in vivo will be a good one? So we need a better predictive model, and all of this we need to move all of it out of the lab to the clinical trial. So for my take-home message today, first we need a site-specific needs of the ankle cartilage, because it's not like the knee cartilage. With its unique biomechanics and biology, with the different consideration that require. And we need to think beyond the traditional to explore more advanced option. And this field is rapidly evolving, so we kind of need to follow the new technology that emerge. And the key of success is to collaborate with the interdisciplinary approach, not only the surgeon, but also with the engineer and biologist. Thank you very much.
Thank you. From the floor, do you have any questions or comments? I would like to invite all of the speakers on the stage in order to answer the question.
So may I ask Dr. Tunyapuk? So suppose that I'm a doctor outside of the large center hospital, and we have a cartilage defect at probably a lunate or something. I see that you use a scope, right? Arthroscopy. So are there any substitute for probably wrist arthroscopy? I'm not sure, to save the cartilage, or what do you say? Or is it like a mandatory thing to bring them to a large center hospital to get it done to probably restore their cartilage?
Mainly for the upper extremities pains, about the pains. If you can manage the pains, you can do with the conventional by injection, steroid, or you can do fusion. And if you would like restoration, that means you would like to maintain the cartilage congruity. So you can check with the fluoroscope as a conventional way. But in the fracture case, I think if you have opportunity to reduce and maintain the cartilage surface with directly your directly vision, I think, is probably better. But the evidence compare between the fluoroscope and the arthroscope is equal, I think. But technique for reduction, if you use arthroscope, maybe easier. So in distal end radius, I think if you can, manipulate the fracture and make it very smooth, good choice. But the cartilage defect itself, I think focal cartilage defect in upper, you can do with the fibrocartilage regeneration. You don't need the hyaline cartilage. The conventional, I think, still the same. But in the late stage, you can do fusion in the remote area. Fusion is okay, I think. But if you do something new, or if you're concerned about regeneration, you have to use the arthroscope, I think, for make it minimal invasive and joint preservation.
Thank you.
And thanks our speaker for your very inspiring lectures. However, I still have a question about the cartilage tissue engineering. Do you think that all cartilage lesions should have tissue engineering to get the hyaline cartilage as usual, or just some of the lesions that need tissue engineering? All of you,
Okay.
what do you think?
This is a good question. I'm going to explain this in the next talk, in the following section. Well, I think if the tissue or cell being engineered, it is not equal to the primary one. The original, let's take chondrocyte as an example. The primary chondrocyte, if you do the culture, first passage, second passage, and third passage, the phenotype change. And if you tissue engineer the cells in vitro, then you have to use the nutrient in the in vitro condition, oxygen, tension, nutrition, temperature, all these matter concern. But everyone neglected the in vivo condition. We have a neural and hormonal control of the cell growth. But in the in vitro, there's no neural, no hormonal control. So this is a good question. The tissue engineering, if tissue engineered or cell engineered, it is normal, not equal to the original one.
Okay.
So I will explain that more detail in the next topics.
Thank you, sir.
Okay, for my understanding, your question is whether all cartilage lesion need to be repaired. Okay, because if we want to repair the cartilage, I think it's follow the principle of tissue engineering. Either we do the engineering or not. Like, every repair requires cell, require the scaffold, by natural scaffold, by just a fibrin clot, or by the artificial scaffold that we put in, and also the signaling molecule and bioactive molecule that we have in our body, or whether we put it in. It's following this principle. So first, I think the question is, do we need to repair all the cartilage lesion? It depends on the patient and the site specific. For example, I have treated my old patients with osteofrontal lesion by just removing it and no repairing at all. I didn't even perform microfracture. I just removed the fragment and then left it. And the patient was improved. And I didn't concern much about OA change in the future, probably because of the size that's small and her age that she may die before it happened. And so first is the patient need the cartilage repair or not. The second thing is which joint is it and how much size is it? Because if it's like Dr. Tunyapuk mentioned, if it's upper limb, I think it's less serious than the large joint, the weight-bearing joint, and the size of the cartilage compared to the resting, the remaining area of the cartilage in the joint. So I think that's the question that do we need to repair it? But if we want to repair, then like I said, it's follow the principle of tissue engineer. Either we repair by just marrow stimulation, that's our body will fix itself, or by formal tissue engineering by the scaffold and by molecule. Yeah.
For me, I think first is concept of joint preservation first. Let it very close to the nature before injury. You have to get the concept of joint preservation because if you get the nature joint, you will get the longevity. Longevity is the key of tissue engineering. At the moment, longevity is not good. Maybe TKA is okay, but longevity is not good. Biological restoration of cartilage, you get longevity. The longevity is the normal one. Turn the injured one to be normal. Very difficult. Not yet. Longevity is not good. So when compared to the reconstruction for the material, it's different. For the upper, fibrocartilage is still okay. But the knee fibrocartilage is not enough. It's not enough. You have to turn to be hyaline. That's my answer.
Thank you. Are there any questions from the floor? So I should ask more questions. For we have to tailor. It means that the material for scaffold or the cell type that you use for tissue engineering should not be the same, right? So in the hip, what would you prefer? And in the ankle and also in the elbow, maybe you can answer for the knee.
Well, if you have attended my video presentation yesterday, the matrix we used is there are two types. One is calcium triphosphate. It is a bone substitute, have been used in body for many years. The other one is PRA-PGA, polylactic acid and polyglycolic acid. This material is used for the suture material, Texon. So it has been used in body for many years. So we use these two materials, calcium triphosphate and PRA-PGA, to construct the matrix. So it can use in every part of the body. So our medical device get approval from Taiwan FDA for knee application. But if the doctor get approval from the IRB, they can use off-label use on the ankle, on the elbow, on the other place of the body. And right now we have accumulated, this product have been used in Taiwan for 5 years. So currently we accumulate about 1,000 clinical cases for measure on the knee, but some of them use on the tailor, on the ankle joint, elbow joint, even in the wrist joint. They also get a good result. So your question is, different joint use different material? No, I don't think so. We use the same material. The material has been used in body for many, many years.
But the quality of the material that you use, like biomechanical properties, you use the same material. It means that it can tolerate all the force in any joint, right? So what do you have to tailor to because you use the same material,
you mean the
same
size,
structure,
right?
and what is the difference between joints?
It is a small. The matrix is a small cylinder one, 8 millimeter in diameter and 8 millimeter in depth. So we can use same material in different part of the body. So if the area is large than like a 2 centimeter or 3 centimeter, we can use multiple matrix to repair the lesion. Same material in different area. and the area is bigger, we then use more matrix.
So I answer only elbow specifically. The elbow, you have to see the lesion first. If contain lesion, lateral is good, lateral wall is good. You can use the matrix, like the collagens or even the scaffold-free techniques, like the grooves and the cell is okay. But if the lateral bones broken is involve the lateral wall of the elbow, you need the very strong material to protect, make it uncontained to be contained techniques. So you can use other autograft from bone and the crest is okay. And cartilage, you use different one. But you have to make the contained defect first. And you can see the matrix after that, I think, for elbow specifically.
So for the ankle, okay, you want to ask me what it should be tailored for the ankle cartilage. According to the character of the ankle, I think the perfect character of the material or scaffold for cartilage engineering is first, it should include ore as a material that can develop into both cartilage and bone, because the bone lesion and cartilage lesion usually come together in the ankle. The second thing is it should be kind of injectable and work in vivo due to the constrained ankle mortise that's difficult to access, and to avoid damaging more by osteotomy or some other kind of procedure to access is the best if it can be kind of injectable one and work in vivo to avoid like to implant the ex vivo cartilage scaffold. And the third thing is it should be some kind of material that's has a stiffness that's higher than the one used in the knee, or can turn to be the one that's have a kind of mimic character of the ankle cartilage, low water permeability, higher stiffness, and higher modulus. I think that's the character of the scaffold or material for the ankle cartilage that it should be.
Thank you so much for all of the comprehensive explanation. We should stop this session, and thank you so much.